everyone, so my name is Shauna Johnston. I am an Asthma Specialist Nurse for the Knowsley Community Respiratory Service, and I've just come on to talk about what we've been doing within the Knowsley area. So we've been optimising asthma management within Knowsley PCNs. So today I'm going to talk about, just going to give an introduction and overview, an introduction to the framework, the PCN pathways and outcomes, asthma guidelines and diagnosis in veno testing and veno testing in practice. So we're currently doing a project in Knowsley where we're identifying high-risk patients on the GP asthma registers. We're running searches across Knowsley Primary Care, which are a collective of 11 practices across all 3 Knowsley PCNs. This has been nurse-led and we have prioritised for optimisation through the service. So we have searched using tools to identify the patients that are most needed support from this approach. So working across all the primary care Knowsley PCNs, there is 5 practices operating from 11 locations in Knowsley. This gives us a total of over 52,000 patients, which represents around 1/3 of the Knowsley population. For the asthma patients, we have divided into high and medium risk groups, and these patients were prioritised. Patients who were currently on an inhaled steroid were placed on a lower priority as they were seen as lower risk. We have been using the Veno machine in patient reviews, and this can tell us how well the patient's asthma is managed and can determine the treatment pathway. The severe asthma patients are already under an asthma specialist, either the Liverpool Severe Asthma Service or Wythenshawe. So these patients don't need a clinical review. There has been a mixture of face-to-face and virtual, initially seen by ourselves, the specialist nurses, and this will be taken over by our physician associates. There was 2,673 patients in total, and there's 1,069 to be seen. So how did we characterise our patients? So we characterise into separate groups. So group 1 is the known severe asthma patients, and these patients who are on asthma biologics and who are already under a regular follow-up with the severe asthma clinic. So these patients do not need to be seen by us. Then group 2, these are the patients who are seen by us and the physician associates for a face-to-face review. So we check their optimal therapy, titrate if appropriate, ensure action plan is in place, check adherence, inhaler technique, review triggers, exacerbation management advice, exacerbation safety netting, veno as required. We can also arrange spirometry with further veno testing, refer to the Knowsley Integrated Asthma Service as indicated, and these patients are under discussion with the asthma consultant if needed. Then group 3, the low risk group. So these patients are not actually being seen, they are having an intervention and being sent a text message, an email or a letter, encouraging them to check their inhaler usage and technique, referring to right breathe, signposting to education, exacerbation management advice, signposting to appropriate information such as lifestyle, smoking cessation, exercise advice, and safety netting. Then so group 3 was divided into group 2 groups. So the medium risk group, these patients are seen by the practice nurse in their local GP surgery. So these patients are optimised and titrated where appropriate, reviewing triggers, checking adherence, exacerbation management, repeating their asthma control test in a month, and if they score between 0 and 15, they are to be escalated to the high risk group. And they're also safely netted as well. So how did we identify our patients? So the total number of patients in Knowsley is approximately 52,000. Total population of practices taking part in the work is approximately 17,000. So the total number of asthma patients is approximately 1,700. So we identified these patients on the asthma register following prescription collection information to identify the following groups. So they were divided into 5 cohorts. So cohort 1, there was 36 patients who are using more than 3 SABAs in 12 months with no other inhalers and having oral steroids. Then cohort 2, there was 281 patients that are using more than 3 SABAs in 12 months with no other inhalers and not needing any oral steroids. Then cohort 3A, there was 500 patients using more than 3 SABAs in 12 months with less than 6 ICS LABAs or ICS LABA-LAMA in 12 months. Then cohort 3B, there were 350 patients that were using more than 3 SABAs in 12 months and less than 6 ICSs in 12 months. And then cohort 4, there were 2,808 patients that are using more than 3 SABAs in 12 months and more than 6 ICSs or ICS LABAs in 12 months. So cohort 4 were the low risk group who were had an intervention. So they were divided into 5 groups. So the red, amber and green. So red being the high risk group. So these are patients who were not on an ICS and needing oral steroids and using more than 6 SABAs in 12 months. Then the amber, they're already on an ICS, but they are picking up too much SABAs. And then group 5 is the green group. So they're the patients who are just having an intervention to encourage inhaler therapy. So in practice, we've seen the red and amber groups, and depending on their pheno, whether it's high or low, helps us make a clinical decision of whether or not we're going to start treatment, step up treatment, step down treatment, or if we're querying the diagnosis, then we will send for a spirometry with reversibility. So how does this work in practice? So we are doing face-to-face appointments for diagnosis and optimization, checking adherence, education, inhaler technique, checking optimal therapy and titrating where appropriate, exacerbation management, safety netting, providing education, reviewing triggers, ensuring personalised asthma action plans are in place, pheno testing, referring to smoking cessation and pulmonary rehab. These patients are for discussion with the asthma consultant if needed. We can also arrange spirometry with pheno testing, and we can refer to the Knowsley Integrated Asthma Service as indicated if we're querying the diagnosis or if there's possible smoking-related lung disease. So during our assessments, we want to make sure we conduct a thorough review. So with that, we do subjective assessments such as the asthma control test, the RCP 3 questions, the breathlessness score, reviewing symptoms and finger clubbing. Then general assessments, checking adherence, is the patient taking their inhaler every day, are they picking it up every month, exacerbations, smoking advice, occupation and asthma severity. Also objective assessments such as peak flow readings, inhaler technique, hematology, eosinophils, saturations, pulse if indicated, chest examination, BMI, chest x-rays, pheno testing, historical spirometry and previous hospital admissions and ITU admissions. We're also providing lots of education around SABA over-reliance. So why are they picking up their SABA every month? Are they using it for symptom control? And a lot of patients just pick it up every month because it's on the repeat and they're not actually using it for symptom control. Or they're using it for other reasons, maybe anxiety. A lot of them use it as a comfort blanket. So a lot of education just around SABA over-reliance. Also triggers, personalised asthma action plans, smoking cessation and pulmonary rehab. So where are we now? So we've seen 452 patients. 387 of them have been face-to-face. 65 have been telephone consultations. 169 have been stepped up and had a change to treatment. 2 patients have been stepped down. 44 patients have had a device change. So out of the 452 patients that we have seen, 309 of these patients have brought their inhalers, and 92 of these patients have had a poor inhaler technique. So that's a third of our patients with poor inhaler techniques. 42 patients have been referred for diagnostics, and 0 have been referred to the severe asthma clinic. So what happens next? So once we finish the project, we will review the prescription collection 6 months after the last patient has been reviewed to see are they still picking up too many SABs, and following that we will send a letter encouraging ICS use or optimization clinic appointment, and this will be analysed and reports will be reports and manuscripts will be written. So it'll be interesting at the end of the project to see if we've made an impact. And then the next steps would be, this is going to be rolled out into other practices within the Knowsley PCNs who have all committed to the work after seeing how we've done. So what is our goal? So our goal is to have good asthma control, so complete control, no daytime symptoms, no nighttime symptoms, no need for any antibiotics or steroids, no asthma attacks, no limitations, normal lung function and minimal side effects from their medication. So I just wanted to mention the Veno. So that's what we are using in clinic at the minute, and the Veno testing is recommended by the BTSI guidelines, testing for eosinophilic inflammation. So then it's also really good for diagnosing asthma too. So in adults, the Veno level, if it's above 40, is considered as a positive test. So we are using the Veno testing in practice for both diagnostics and optimization. So Veno is also recommended by the NICE guidelines. So for diagnosis, it does allow diagnosis for allergic airway inflammation or not, provides objective evidence to support the diagnosis of asthma, and also gives clinicians the confidence and the confirmation, and it determines the likelihood of whether the patient is going to have a response to an ICS. It also aids differential diagnosis of respiratory symptoms which may not be due to asthma. So using the Veno testing for management and optimization. So it supports asthma management in people who are symptomatic despite using an ICS. It assists dose titration and anti-inflammatory treatments, and it also helps us monitor treatment response and also detect non-adherence to ICS.